Welcome to The Waiting Room. This is a podcast where you and I gain first-hand insight into the world of healthcare by directly speaking to the professionals who live it every day. From the science behind each specialty to the stories that shape them, each episode brings you expert knowledge, practical advice, and a closer look at medicine and where it's headed in the future.
In today's episode, we decided to focus on orthodontics. We decided to interview Dr. Greg Greenberg from RxSmile here in Frisco, Texas. He graduated from Baylor University and got his certificate from Columbia University. He's been practicing for over 37 years. Let's dive into it. So, welcome to the Waiting Room podcast. My name is Yash Moore.
My name is Rehan Mohammed, and today we're joined by Dr. Greenberg, a leading orthodontist from RxSmiles in Frisco, Texas.
So, Dr. Greenberg, let's talk about your journey and how you got here. So, why did you want to become an orthodontist? What was the goal behind that?
Well, first of all, let me say thank you to you guys for having me on the show. I appreciate it. Be able to tell a little bit about my story. Orthodontist of 35 years. My start came when I was about 13 or 14 years old, and I had orthodontics myself. I had a large overbite, and my teeth were not in the best of shape as far as how they looked. I was taking care of them, they just didn't look good. So I had an orthodontist do work on me and kind of fell in love with what he was doing and the results that he got from other people as well as myself. And I kind of was blessed that at an early age to kind of make a decision to know what I wanted to do. And that was a goal that I set from basically age 14.
Wow. Did you always envision yourself in healthcare, or was it always just orthodontics?
No, it was going to always be healthcare. My father was a physician. He was an internist, a general practitioner, and ran his own business. He was his own doctor, and I always liked that. I always liked the idea of being able to run your own shop. I liked healthcare. I wasn't that crazy about going to medical school, primarily because my dad would be interrupted a lot of times during family time because he had to go to the emergency room and meet a doctor or meet a patient or something of that nature. Medicine has since obviously evolved, so now there's hospitalists and emergency room doctors. So if you were an internal medicine doctor that had a patient with a problem, you just tell them to go to the emergency room and the emergency room would handle it. As a physician, primary care physician, you wouldn't necessarily have to go. Back in the old days, he would have to leave the dinner table and go, or leave a movie and go meet his patients. That never really appealed to me very much, but the idea of running your own business very much appealed to me, so I went the dental route.
Okay. Has orthodontistry changed over the time you've been practicing?
Oh, immensely. Yeah, there's been there's been changes on basically every front, from the consumer front, the type of consumer that orthodontics appeals to now, from the technology that we have available, how you're running a solo practitioner. I mean, when I first started, most of your listeners might not know this, but a pegboard system, which is an accounting system that was all done with carbon paper, and you did it all by hand. There were no computers generating statements, and we would mail out statements to patients every month. It was very old school back in the day. So technology as far as running a business has changed immensely, but technology, and we'll get into talking about the technology that's changed, how you practice orthodontics as well has changed.
Yeah. Let's talk about that a little bit, actually. Brace wires, how have they contributed to treatment, and how do they work really?
So the wires that are predominantly used now in orthodontics are nickel titanium wires, and that which have a permanent memory to them. So once you form the shape of the wire, you can bend it as many times as you want. It maintains that shape. There's no permanent deformation. That changes when it heats up. So obviously when it gets in the mouth, it warms up and it starts to move. Those wires and that metal was developed by NASA years ago. So it's one of the advances that helped you and me that came out of the NASA program, along with the multitude of others. But the nickel titanium wires is probably one of the bigger advents that's come in the last 50 years for orthodontics. It provides a lighter force on the tooth so that the patient feels less discomfort, and it's biologically safer to move the tooth at a lighter force than it is a heavier force. Back in the day, there was you'd use a stainless steel wire. So it's kind of like putting a coat hanger of sorts in there, and the level of force initially that was put in there was very, very strong, so the patient would feel it, and then it would decay quickly. So after maybe a week to 10 days, that wire wasn't really functioning as well as it could have been because it's been deformed or it's kind of used up its strength. Nickel titanium wire, again, back to how you practice orthodontics, rather than seeing a patient every 4 weeks, we see a patient every 8 to 10 weeks with a nickel titanium wire, because that wire is working the whole time. You're getting action out of it, and the patient is having less discomfort from the lower forces.
So like, what's the problem with having like such a strong wire? What can
Well, the biggest problem is danger to the tooth. You're biologically moving a tooth. You don't want to. What you're trying to do in a perfect world is trick the tooth into moving without any, the minimal force necessary. Which, if you see people with crooked teeth, their teeth they never really hurt when they went crooked. Their body just created that situation. So we're trying to duplicate that. So the lighter the force over a longer period of time allows for a healthier supporting structures, your bone, the gum tissue, the tooth itself, so you're not doing any damage to that.
So, like, in terms of braces or like Invisalign, what do you think your patients like come in like with the biggest misconceptions, or like what are their false stories that they hear?
Probably the most common is that they think it's going to take less time than it does. Particularly with adult patients, they want to come in and get it done in 2-3 months. Again, depending on what we're doing, if it's a full mouth comprehensive treatment, that's not something you're going to accomplish in 3 or 4 months. If you've got 1 or 2 teeth that you don't like where they're positioned, that's something that can be done as a limited treatment. But the biggest misconception is it still takes, while it takes less time than it did 20 years ago to go through treatment because of some of the technology, it still takes a period of time to do it safely. And as I tell my patients, look, there's nobody that wants you out of treatment faster than me.
Yeah.
I don't want to drag this out. I'm trying to get you out as fast as possible.
Yeah. So like when I was a kid, I had like phase 1 braces. Like,
Yep.
I had braces like for like a few years, like a year, and now I'm having braces again. So what's the point of these like multiple phases of braces?
Great question. So multiple phases, or phase 1, phase 2. Phase 1 is more growth oriented. So we're seeing patients that are age-wise generally around 7, 8, 9, 10 years of age.
Right.
They're growing rapidly at that time, and the patients that require or would require a phase 1 are patients that have some type of skeletal imbalance with their jaws. They have an underbite, they have an overbite, they have a crossbite, they have a crowding situation, they have an open bite. There's things that we can do as orthodontists to intervene and change the growth of their jaws or make more room to correct those things. Whereas when you get to be 13 or 14, the majority of your facial growth is complete at that point. Still a little bit left depending on the individual, but the majority of it is completed. So you're really not able to accomplish some of the skeletal things that you would want to do to fix it. You're just able to move teeth around. So then it becomes more of a compensation of how do we cover up some of these problems, but because we didn't fix them in a first phase. To throw some numbers out, I always tell parents, probably about 50% of the younger kids that I see for an initial evaluation don't require a first phase. They're looking good, everything's coming in the way it's supposed to, everything's growing the way that it's supposed to. So we just put them on a growth and observation and see them every 6 months until the permanent teeth are in when they're a little bit older, and if they need braces at that point, they just do 1 phase. Right. But most first phase patients will require a second phase later. Because you're not straightening the teeth at that first phase, you're just correcting skeletal problems.
But like, are they making room for like the new teeth to come?
Yes.
Like adult teeth?
Yeah, if it's a crowding situation, you're making room. What we're trying to do in that situation is avoid extracting or removing permanent teeth. Again, that was very common back in the 50s and 60s. If you were crowded, you didn't do a first phase of treatment, you just removed 4 permanent teeth. And in hindsight, who wants to lose 4 perfectly healthy teeth if you don't have to? And there's some airway considerations there as well. The smaller you make the arch form, the smaller your airway can be. So you want to try to do as much as you can to bring everything, widen it, bring it forward.
Okay.
So like, how do you decide like what type of people need like early intervention versus like waiting until the most permanent teeth have like came through and like?
How does that decision take place?
Yeah,
through an exam. Just you examine the child and you see. If you know what you're looking for, it's pretty obvious to see what it is. The hardest part is communicating to the parents sometimes that this is really a necessary step. You're really doing your child a disservice by not correcting a crossbite, if you will, or not making more room for teeth.
Right.
Mm-hmm.
But it's very successful. Again, when you went through it, gosh, it takes about a year,
right.
Sometimes 14, 15 months.
Yeah.
So you're kind of in and out pretty quickly. and then you're just in that observation phase for a year or two until the permanent teeth come in.
So what's like a treatment timeline? So patients come in, what goes on?
So first phase, 12 to 14 months, expansion, overbite correction, those types of things take place. Second phase, or comprehensive treatment, and that can be anything from a teenager to an adult. Treatment timing, generally in the old days, 24 months. With the technology we have right now, with both the nickel titanium wires that we talked about earlier, as well as what the brackets that I use, or the braces that I use, which is called PSL, or passive self-ligation. These are brackets that elicit less friction on the wire, so that the tooth is able to kind of move easier without as much resistance. And I'd say my average treatment time now is probably around 16 months. Some people will go 20, some people will go 11 months and be finished. So it's a considerable difference from where it was 20, 30 years ago. And as we're talking about technology, passive self-ligating brackets are one of the most significant advents of the last century, or the last decade, I should say.
So, can you explain the behind scenes, how braces actually move, or do you remodel them, or both? Or
Yep, good question. So what actually does the work is the wire. So once you attach a bracket to a tooth, that's just an extension of the tooth. So now you're taking that tooth, in order to move it from point A to point B, the wire does that work. Okay. So it's very important to put the bracket in the proper spot on the tooth. It's also very important to have the right bracket on each tooth. So every tooth has its own bracket for that tooth, so that it provides the right torque, angulation, and positioning for that particular tooth. And we can get into talking about technology in a minute, about 3D printed brackets, because that's kind of the direction that the profession is going. But the actual wire is what moves the tooth, and what you're wanting to do, you're breaking down bone on one side and you're adding bone to the other. So if you envision a bottle of water being pushed across the room, this pressure is pushing it. There's cells that are breaking down bone over on this side of that tooth, and there's cells over here that are laying down new bone on this side. This is osteoclast and osteoblast. So as it moves, you're actually moving bone with it. Okay. So it's not like a boat going through the water. It's kind of the water coming with the tooth. Does that make sense?
New teeth are forming while you're...
Yeah, new bone is forming around the tooth.
Okay.
Yep.
Okay, so you're talking about braces materials like metal, sapphire, and ceramic. So how do you determine which is used on a patient and what is best? So,
but for the most part, I allow the patient to make a decision, because the difference between metal and ceramic is aesthetics. It's not stainless steel, it looks tooth colored. There are a little bit of limitations because you're using a ceramic bracket, so you have to be careful and using a little bit lighter forces at certain points during the treatment. It's not a deal breaker. Some people say, I want to do ceramic, that's fine. There's very, very few instances where I would say, look, I really just want to do metal braces on you. It's going to be a faster, easier treatment. But that occurs, again, depending on the positioning of the teeth. So the materials themselves, as far as ceramic versus metal, you're going to get the same end result at the end of the day. Just stainless steel is a little more durable. And what's happening in the industry now is that we're getting 3D printed brackets. So now you're getting a bracket that a 3D printer is printing that's specific to that tooth and that patient. So it's basically a fully customizable system, which is, again, a little decreasing the treatment time, because you're not what we call round tripping. You're not going from over here to here to here with the tooth. You're just making a straight line. So you're kind of decreasing the amount of time that it takes to get from point A to point B.
Now, let's jump into a little bit of the technology. And I know that there's been a lot of technological advancements recently. So how has digital tools like 3D imaging and maybe even AI transformed your practice?
So I guess it's about almost 10 years ago we kind of went all digital here. So there's a number of ways. Number one, that back in the old days you would take impressions, the gooey stuff that went into people's mouths. That's gone. We do everything with a 3D iTero scanner. So you take a scan of the teeth, it's very accurate. It gives you an STL file. You can then 3D print the model, something that looks like this. Or you can send it off to a lab and have something made just from that model. You don't have to pour plaster. So 3D scanning has been wonderful. Doing a CBCT, which is a more accurate panoramic film that gives you three-dimensional perspective on the patient's skull, allows for better diagnosis, better field of view, better be able to pick up certain things and look at where the teeth are, all the way down to the roots in 3 dimensions instead of just 2 dimensions. The 3D printing of the brackets is, a new technology. They're getting to 3D printing of aligners, so that right now when they fabricate Invisalign or Spark or Angel aligners, a number of different aligner companies out there, they're actually printing a model and then they're fabricating the aligner off of the model. So if you've got 30 aligners, top and bottom, that's going to be 60 3D printed models that are fabricated with all that resin. Then you make the aligner, and then you got to do something with those models and that resin. What do you do with the disposal of that? They're getting to the point where they can just 3D print the actual aligner. They don't have to get a model and print it off of it. They're there. It needs a little bit of refinement, which will be a really good thing for the profession.
So when you're looking at like teeth and stuff, how does AI determine like the tools being used and outcomes of the teeth, like before and after?
So we're doing some what we call indirect bonding. So we're able to take a scan again, put that on a computer model, and then position where I want the brackets on the tooth. And then with the assistance of AI, we can then fabricate a tray that the brackets fit into, and then that tray just slides on the teeth with the brackets in them, and we transfer the brackets from the tray from a computer generated model to their actual patient. So rather than the orthodontist sitting at the chair positioning right there while you're sitting there, a bracket at a time, you're able to put 8 of them on at one time, all in what looks like a mouth guard, and you just put it on. That's one of the ways. Obviously, the way AI is integrated into our whole world has changed, and it's changing pretty much daily. So, being able to look at diagnosing cases and throwing that out there for AI, maybe you get something that picks up that you didn't know about, that there's data that you can look at a little deeper. So it's very positive for the consumer, that's for sure. It just brings more to the table.
Right. So I'll go ahead. So what do you think is your favorite technology that's being introduced at this time?
In all of the field of orthodontics?
Orthodontics, yeah.
I've enjoyed the passive self-ligating brackets the most, just because I've seen them the most change in ease of treatment on both sides of the chair, both from the doctor's side as well as the patient's side. So the comfort level that they get from having lighter, fewer wires, the increase in time between visits, so you're not having to show up every month, and then from the doctor's side, it's just it's simplified. You're going through the motions of straightening the teeth, much simpler than it was 20, 30 years ago.
Right.
So you think like the introduction of all these like new technologies and stuff would reduce like patient treatment time and like their satisfaction rates?
Absolutely. One of the things that we were going to talk about is the direct-to-consumer market. I'll segue into that. Smile Direct Club, Candid, Bite, there's a number of them. For the most part, they've kind of gone away. They didn't survive, which was, in my mind, predictable, because you really need doctor supervision if you're going to be doing something like this. But what they did do, those companies, those direct-to-consumer companies, is they brought awareness about orthodontics to people that probably otherwise would have just discounted it. In other words, if you had some crooked teeth and you were like, yeah, I'd really like to straighten my teeth, but I don't want to spend $7,000 to straighten my teeth, but I can do it over here for $2,200. I'll just send it off and they'll send me some aligners. It's a little more involved than that, as most people found out. But what it did do is allow for more people to be aware of the fact that, hey, I can get these teeth straightened, and it may not cost me $7,000. I can go to my neighborhood orthodontist and let them take a look at me and maybe do some limited treatment and explain I don't want everything done, I just want some things fixed. And so it really opened up a much larger market, and that was, of course, with aligners. So, and the aligner market continues to grow both here and abroad. They have products, meaning Invisalign is the one that I use predominantly. Products for kids for phase 1. We can now do phase 1 orthodontics with Invisalign, which 10 years ago was unheard of. Most teenagers would opt to not wear braces if they didn't have to. They can wear aligners. Again, the trade-off there is compliance, because you got to keep up with them. They're removable. You got to know you're wearing them 22 hours a day. So if you make that commitment, you're gonna it's gonna be a lot easier process to go through your treatment.
Right.
So like branching off of that, in what scenarios would you recommend like aligners over traditional braces, or like vice versa?
Predominantly, there isn't a whole lot you can't do with aligners that you can do with braces. If you're doing a surgical case, if somebody needs jaw surgery, you're going to most likely do braces. Although it's doable in aligners, I've done it. It's a little more difficult, but basically it comes down to compliance of the patient. It just comes down to are you, the patient, going to commit to wearing this 22 hours a day? Are you going to make sure you put it back in after you're done eating? And if you commit, you're going to have no problems. It's the patients, both teenagers and adults, probably more adults than teenagers, to be honest with you, that just can't get that 22 hours a day of wear in for their aligner. You switch the aligners every week, so every week you're getting a new set, so you're just sequentially moving the teeth. But if you're not keeping up with it, then you're not moving the teeth, so you kind of have to back out and maybe go back and do braces because that wasn't a good option. So the hard part is for both the consumer as well as the doctor is weeding out the patients that are the best candidates for it. Because a lot of times I'll have an adult that will come in and say, I'm doing braces. I tried Invisalign last year. I was a terrible patient. I never wore it. It was a bad decision for me. I should have known better. I'm not that type A of a person that's going to keep up with it. So I'm just going to go with braces.
So do you think like both methods are like equally effective?
In the right hands, yeah. I mean, you have to have somebody that knows what they're doing. There's a lot of people doing aligners that don't have the experience, so they might be trying to do a more difficult correction with aligners and just not maybe have the knowledge to do it. So it takes some knowledge and skill to be able to do it with aligners.
So you were talking before direct-to-consumer aligner companies. What should patients consider when choosing the treatment path?
Having a doctor supervision. I mean, you can find an orthodontist that will treat you without spending buying a new car. They're out there. Not every orthodontist wants to do what we call limited treatment, but they're out there. And it's just a lot better for you as a consumer to have somebody supervising the treatment and somebody to talk to during your treatment if you're having what you think is an issue. Something's not looking right, something doesn't feel right. The direct consumers, what are you going to do? Email somebody for a helpline? It's just that, which is one of the reasons that those products have just not lasted. They just haven't made it.
So like, what are some of the potential risks without like the proper supervision, and like in terms of aligner use? You
can lose a tooth. You can move a tooth completely out of bone. So there's nothing worse than that.
Yeah. So
sometimes if you move it too fast, you're putting too much force on the tooth. Mm-hmm. It can flare up and it can require a root canal. You can damage it to the extent where you have to remove the nerve and the blood vessels from the tooth. Fracturing a tooth isn't really going to happen. That's too much force. That's more of a trauma. But predominantly, it's just trying to do things with the aligners and move the tooth into a position that's just not feasible. It just can't happen.
Yeah. So, as you were talking about earlier, and like a lot of patients are like interested in like shortening their time, like their treatment time. So, what are your thoughts on like accelerated orthodontics, like techniques that are being used, like power chains or like bite blockers? So,
power chains will close space. They're very, very effective. One of the products that, again, a newer technology that was out there was a vibratory device, a couple of them on the market, that would, a certain wavelength of impulse vibrating on the teeth would increase osteoblastic activity. Those are the cells that create bone. They also would help seat the aligners a little bit better if you're doing a aligner treatment. And there's science behind it. There's no question about it. It's not something that's new. It's been around for a long time. Just adapted over to orthodontics. Used it for a little while. Again, my biggest issue was getting people to comply to use it. If they use it, they would move through the treatment faster. So some people it was good for, some people it wasn't.
So would it be suitable for so it's not suitable for all patients, or do you like make the decision for them? Or
well, I don't even offer that vibratory technique anymore, just because it was not, I wouldn't get where I was going to. It's an add-on cost, and it really wasn't getting us to where we wanted to go.
Mm-hmm. Can you explain micro osteoperforation, how it works?
Yeah, so what you're doing with osteoperforation is essentially if you have a tooth that's not moving, you've got a stubborn tooth, or it's what we call ankylosed, means it fuses to the bone, which can occur on certain occasions. Essentially what you're doing is you're taking a very, very small drill bit and you're making perforations around the root in the bone of the tooth Think of it as a perforation if you're opening up an envelope and it's perforated. So you do that all the way around the tooth, and it's introducing basically trauma to the bone, so an inflammation to the bone, and the response, your body's response, is to heal it. So you're just speeding up that process of breaking down bone and having new bone form. So it's a successful. It will move teeth faster, no question about it. Downside again is cost, because you've got to see a periodontist or oral surgeon to do that procedure. Obviously there's some pain involved with the procedure because you're doing a surgical procedure. It's not surgery, but they're still punching holes in there. And then you've got to increase the number of times you're seeing your orthodontist too, so you're not going 8 weeks in between visits necessarily, or 10 weeks, but effective nonetheless.
So we were talking about the timing of orthodontistry, when it should happen for younger patients especially. When do you determine that time, like when braces should be put in?
For the patient?
Yeah.
I always tell parents it's not a chronologic decision, so if your 11-year-old isn't ready or your 15-year-old isn't ready, it's more of a dental development time. So once all of the adult for comprehensive treatment, once all of the adult teeth are in, that can be 9, believe it or not, that can be 16. So when all those adult teeth are in, or the majority of them in and the last few baby teeth are falling out, that's the kind of a green light time to get started into treatment.
So like, how did children growing up like impact the treatment plan? Like if they like break a tooth, or like if they like chip something, like would that like influence like the treatment process and like going into like
going into treatment? Yeah. Whenever there's been any kind of trauma to the tooth, someone fell, knocked a tooth out, chipped a tooth, you don't want to add to that by adding additional trauma by moving the tooth. So, sometimes people will come in and say, I knocked my 2 front teeth out on the playground. They had to reimplant them. They're not in the right spot. They just put them back in so you don't lose the teeth, but you want to let them heal. Generally a couple of months is sufficient to see if it's going to heal properly. They don't need a root canal. And then you can start using light forces to move the teeth around gently. We got to observe it. Bad things can happen, whenever you've got a compromised situation and you've already had some trauma to it. You don't want to add to it, but you want to get them out of occlusion the way they're meeting, so that they're not doing more damage to the teeth as well. So there's kind of a balance there.
So if your teeth are damaged, like you have bad dental hygiene, how does that influence like orthodontistry?
Well, bad oral hygiene is a different situation than trauma. If you kind of hit the ground or hit a playground, oral hygiene obviously is self-controlled because you're just not doing a good job brushing. But anytime you have that inflammation where the gums are swelling up, you've got plaque and calculus, basically a periodontal disease. The biggest sequelae to that is when you wear braces is that you're getting the plaque to build up around the brackets, and you get what's called a decalcified area. So again, as I tell the patients, when you eat, you've got foods that are coming into your mouth, carbohydrates. The bacteria in your mouth feed off of carbohydrates, and their byproduct of that bacteria is an acid. So if you can imagine dropping a drop of acid on this plastic tabletop every day, every morning when you wake up, and never wiping it away, you're never brushing your teeth, you're never cleaning it, you're just adding another drop every day. After a couple of months, you're going to burn through the plastic, and it's going to do the same thing to the enamel. You're going to start to see what's a scar. It's essentially burning through that enamel like a cavity, but the bracket itself is sealed to the tooth. So what you're seeing is an outline. So you take the bracket off and you see this little square outline of white lines. That's a decalcification of the enamel that's occurred simply because you just weren't brushing the plaque and bacteria away from the teeth. Then you've got swelling gums and gum disease, which start to lose bone, which is the supporting structure for the teeth. So if you're not doing having good oral hygiene, orthodontics is probably not a real good option for you. You want to get that squared away because you're just going to trade off one problem for another. You may have straight teeth, but you may not have them for very long. They may fall out.
So how do gums affect treatment?
Your gum tissue?
Right, yeah.
Well, that gums and bone are 2 of the big supporting structures for teeth. So without those, teeth get loose and fall out. And you need a certain amount of width of gum around the tooth. And without brushing or taking care of them, that tissue recedes away.
So can you not proceed with the treatment if tissue's been receded?
You should not. That's correct. You need to have evaluation from a periodontist to make sure there's healthy supporting structure for the teeth before you start moving them.
Okay. So When we're talking about extraction, taking out teeth, and not taking them out, how do you determine that when you look at treatments?
By today's standards, most people are non-extraction orthodontists. They really want to get away from taking teeth out that aren't necessary. Now, if you've got, a petite little person with very large teeth, you're not going to fit all those teeth in that mouth, or it's not going to look normal, and that's a different situation. But I'd say 98% of the time in today's orthodontic market, that people are looking to not extract any, wisdom teeth excluded.
Right.
Almost nobody has room for their wisdom teeth. Different story. But as far as taking out healthy permanent teeth as part of the treatment, it's just been discovered that it's much healthier long term to keep your teeth and make room for all of them.
So I'm personally wondering, why do people's teeth come in crooked? Why can't they come in straight?
Oh, that's $1 million question.
Yeah.
I had the answer to that, and we'd be sitting on my yacht next to Michael Jordan. Why is there's a number of views on this. My personal opinion is a lot of it has to do with diet and how much you're using your muscles of mastication in early development years. Our Western culture, we have a lot of processed foods.
Right.
Back in the day when you saw that people didn't have a lot of crowding, they were eating raw meats, they were chewing on sticks, they were doing things that really utilized those muscles that helped develop those facial muscles more so than now. And there was an old study back then in the 70s with the Inuit Eskimos, where these particular Eskimos had never really been exposed to Western culture and Western diet. They were eating whale fat and the things that they did in nature. Well, one generation later, once processed foods were introduced, their decay rate skyrocketed and the crowding of the teeth skyrocketed, just because, again, they weren't utilizing those muscles the way that the old days were.
So eating harder foods at a younger age.
Tougher to chew, yeah.
Right.
Yeah.
Okay.
So, I know we touched
McDonald's
on
doesn't qualify.
Oh, yeah.
Yeah.
No.
So
Chick-fil-A.
Yeah. But, I know we touched on this a little bit earlier about, unsupervised, treatment plans. And
Yeah.
What are your thoughts on, people self-installing braces at home, or, the braces fashion trend, or what are your thoughts behind it?
Bad idea.
Yeah.
Don't be putting anything on your teeth that you're not trained to do. You want to put a brace or something, a jewel on your tooth to make it look different, that's fine. That's up to you. As far as moving the teeth, I think you should leave that to the professionals. One of the technologies that is available now is dental monitoring, and that is, it's basically a device that you can put your iPhone in, put a device in your mouth, and it will take pictures of your teeth with your aligners or braces on your teeth, both on and off, and it can register whether or not you need to move to the next aligner or not. So in other words, rather than me telling you, hey, I want you to switch your aligner every 7 days, instead what I want you to do is I want you to put your aligner in, and every 3 days I want you to take this monitoring device and I want you to take pictures of it, and we can see the pictures. There's an algorithm available that will be able to detect how that aligner is fitting, and you may get a green light to move to the next aligner in 3 days if you've been really, or 4 days, or you may get a red light that says, hey, keep wearing your aligner for another 4 or 5 days. So what it does is it takes that kind of rote, unpredictable, hey, 7 days you're going to switch, off the table, because really the 7 days is not that significant. What's significant is when your teeth have moved to the position that they need to be finished with that numbered aligner or those braces, and then you can move forward. So you're essentially saying, hey, your biology and your compliance is going to dictate when the next aligner goes in. And that's done remotely, so you don't have to come to the office for that. So it's technology that has advanced pretty rapidly in the last 2-3 years. Again, it's an added cost, so you keep adding. Every time there's more technology, there adds a cost to everything. Again, for some adults, that's insignificant. It's like, if I don't have to come to see you and take off of work, I can do this remotely, and I can come see you every 4 months. That's worth a couple $100 to me.
So if more technology is coming in and speeding up the treatment time, but it's increasing the cost, so do you think it's making braces and orthodontistry less available for people?
I think it's more available. I think more and more people are more willing to actually spend the money on this and realize the value in having a healthier smile and certainly having a prettier smile. There was a big orthodontics had a big upsurge right after COVID. People had some money in their pocket. They were staying at home. They weren't working. But a lot of them that I heard came in and said, hey, I was in my Zoom meetings because everybody was on Zoom, and they realized looking at their picture in their Zoom meetings how bad their teeth looked. Right. And they said, well, I'm wearing a mask most of the time now anyway. This is a good time for me to get braces or get Invisalign. Let me straighten my teeth. So there was a big, if you look at the number of cases started, 2020 up through 2024, there was a big spike.
So another topic that we wanted to gain attention to is mewing. I don't know if you've heard of it. It's about tongue position, and it's like, what's your professional opinion on this trend people have been doing?
Oh, I know what it is. Yeah, it's snake oil. It's a waste of time.
Oh, okay.
Yeah, just keep it brief. I don't want to spend too much time on it because I don't want anybody listeners to think, oh, I'm missing the boat or anything. I would go ahead and scroll past that.
Okay. Yeah.
It's not going to change the shape of your face. It's been disproved. There's no science behind it. What it is has been a social media fad.
Oh, okay.
Because I know a lot of people that like think it's helping them, or like,
yeah.
But like in reality, I guess it's.
Yeah, there's a placebo effect to everything. If it helps them, that's great. But there's no science behind it.
Mm-hmm. So, like, retention is another area of like discussion, right? Like, how do you approach like retention strategies and like post-treatment like plans and stuff?
Well, so the important thing to realize is that your teeth they're a dynamic state. They're not static. So there's always forces acting on your teeth, whether it's your tongue pushing out or your muscles out here pushing in when you're chewing, and those forces are light enough to move teeth. So if you're blessed enough to already come in and have straight teeth, and you didn't come in with a real jacked up smile, you're probably not going to have a lot of relapse. But whenever you move a tooth from point A to point B, if you want it to stay at point B, you got to wear a retainer to hold it there. Most of what I do for my retention is after 2 months of having your braces off and wearing your retainer, you'll go to nighttime wear. So you'll just put your retainer in when you sleep. It'll act like a night guard as well as it'll retain the position of the teeth. And that's sufficient to keep everything where it is. If you stop, the longer you wear your retainer, the more stable things are going to be. I would say there's never a point where you can just stop wearing it altogether and expect your teeth to stay in that position. Again, there's forces acting on those teeth. So as I always say, if you want your teeth to stay straight, keep your retainer in at nights.
So sometimes people don't like retainers. Is permanent retainers like also an option?
Yeah, there's some pros and cons to permanent retainers. I've gone back and forth on that in my practice for years. On the bottom, you put a wire behind the teeth. Works really well. I've still got patients that are 35 years out of treatment and their bottom teeth are perfectly straight with a permanent retainer. I will tell you that it's a little harder to keep your teeth clean with it in there. The dental hygienists are not big fans because you can't floss, or it's difficult to get back there and floss. Sometimes they'll bend and the patient doesn't know that the wire, they've bit into something and bent the wire. So now it's not functioning the way that it's supposed to and the teeth can move. It can break and you have to end up going back to the orthodontist to get it replaced or repaired. Removable retainers, you can clean with them out. You don't have to worry about working around a wire that's on your teeth. And you just need to sleep in them. So, and it's difficult to do a permanent retainer on the top because your bottom teeth will come up, and when you close, your bottom teeth come up and touch behind the back of your top teeth, and frequently that's right where the wire is that would hold those teeth straight. So a top permanent retainer is not always very functional anyway. So having said that, you have to wear a removable one on the top. So if you're wearing a removable one on the top, how much more difficult is it to put a removable one on the bottom too when you're going to bed?
Yeah. So I have a bunch of friends that like went through the whole treatment plan and then the retention phase, but like they're not really consistent or like with the retainers, and they wear them like once every 2 weeks, or they're not very consistent. So like, how do you handle the cases of like relapses and like when
we get to put them back in braces or back in aligners when their teeth get crooked again, so they get a phase 3. That's when parents say, is there a third phase? The third phase is when they don't wear the retainer and they have to come back and get braces or aligners again, get treatment again. And generally the parents are going to say, that's not on my dime. I've already paid for 2 phases or 1 phase.
So we want to look ahead. So what trends do you really see shaping the future of orthodontistry?
For right now, the aligner market continues to grow because it opens up for more adults to seek treatment. And now that there's Invisalign has been kind of the elephant in the room for years. They do a lot of R&D, a lot of marketing. There are other companies out there with good products, so they're kind of maybe biting into the market share a little bit. My personal opinion is in the 3D printing of those aligners, which is from a green standpoint is positive. But I think the 3D printed brackets, the customizable brackets that are basically fitting your tooth. Right now you put a bracket on a front tooth, it's got the same base to it for everybody. I'm putting in that same shaped bracket. Customizable bracket takes into consideration the shape of the tooth, and it actually customizes the base to that bracket of the tooth. So when you're working on torque and angulation, that's all incorporated into it.
So I know we touched on this a little bit earlier, but what advancements in materials or techniques are on the horizon and then that are on the front of orthodontistry? So could you go into more examples?
Well, we're not going to, when you say materials,
yeah, materials
in particular, we're not going to get away from stainless steel. So stainless steel bracket, which is a chromium cobalt, kind of like the stain you usually eat off of, that's not going to go anywhere. That's proven to be very durable and effective. There's continued improvements. When they first came out with clear brackets, there was a composite or a plastic. Those would pick up stains. They would break. Now they're predominantly porcelain. So, but again, that's a glass. So they have stress points that are a little bit more delicate than a stainless steel bracket. So they continue to improve on those. Clear brackets are generally a little bit larger than stainless steel ones because of, again, you have to bulk them up because of the stress fracture of the stress that you're putting on it, so you don't fracture the brackets. And then, as I said before, I really think the 3D printing those and 3D printing the aligners, just that whole market share of 3D printing is big.
I see. So how do you see the role of orthodontists and dentists evolving with these changes? Is there going to be less frequent visits with patients, or is it going to be more over the phone contact, or how do you?
It's hard to do it over the phone, although we do a lot of texting, so patients can send pictures via text. But I definitely think that the number of visits, and it's already proven to be this way, the number of visits that it takes to get your treatment done going into the office has decreased considerably if you're utilizing an office that's utilizing the technology that's available. And that's just going to get better and better, particularly with dental monitoring, with the wires that we're using. You can go longer between visits and still get movement and get the tooth in the right direction. Now, you still have to have some supervision. Someone still needs to look at that and say, hey, you sent me in a picture and I don't like the way this one tooth is moving. I need you to come in and we need to see what's going on. But that's going to be the exception to the rule. I mean, for the most part, you're going to set everything up properly to begin with, and you're going to watch this, whether it's remotely, whether it's through pictures. You're going to watch the process just take place. And now the patients, right now my patients are 10 weeks, 8 weeks. It's not unheard of for people to go 3 months, 4 months in aligner therapy with dental monitoring. I even know some practitioners that are giving their patients all of their aligners, dental monitoring device, and saying, come see me in 10 months. You just go through it, unless you have a problem. I'm going to be monitoring you as you put the camera in, and we'll watch what things are going. And if I need to see you, we're going to reach out. But if everything's going smoothly, and for a lot of adults, that it's kind of a love-hate, because a lot of adults say, this is great, I never really want to see you again. Give me my aligners and I can go through my process and I don't have to take off of work. There are other people that say, look, I'm paying all this money. I'd like to see you. I want you to make sure that you're taking care of me and everything's going properly. So again, it comes back to personal preference for the patient, but it's nice to have options and things, different types of treatment variables that are available to the patients.
So we want to talk about, has there been a shift toward more collaboration with other disciplines, such as oral surgeons?
I don't know that it's pretty much always been there. Patients that have severe skeletal problems that need jaw surgery, we work in conjunction. It's very multidisciplinary. There are a number of adults that are in treatment now that need cosmetic dentistry, crowns or veneers done on their front teeth. And a lot of times we work in conjunction with those cosmetic dentists to set the teeth up in preparation for those things. So I don't know that that's going to increase anymore unless more and more adults start coming in and saying, I want to do multidisciplinary, I need X, Y, and Z. It's always available, and one of the things that orthodontists always do is communicate well with the patient's general dentist, because the general dentist is kind of seen as the primary care, the one that's leading the charge. So, and we're kind of borrowing the patient from them for a couple of years as we go through the treatment. So, staying in communication with that individual and saying, hey, this is what we're doing, or if they're planning on doing some work, just kind of making sure you're getting feedback and saying, I know you're going to put a crown on a lower molar at the end of treatment, so I'll put the tooth in the right spot for you and get it all prepped.
Right. So you were talking about veneers. What's your opinion on veneers during treatment? Or treatment?
Any type of cosmetic dentistry would come after you do the orthodontics. So you want to get all the teeth set up first. Veneers are better than crowns. Veneers are, again, just goes on the front surface. It's just a front surface on the tooth. So there's a lot less tooth reduction, which is never a bad thing. Yeah. And again, most of the people that do veneers don't like their tooth color, don't like their tooth shape, don't like their tooth size. So they're looking for that Hollywood smile where they're going to put a different, front 6 teeth on there that look better. That comes after. Like if you've got a patient that's got a bunch of crowding in the front, you can't do veneers on those teeth and make them look right. You can take those crowding and spread them out, and they can still have some ugly teeth, but at least they're positioned in the right spot. Then the cosmetic dentist can go in and make that pretty.
And you were also, I was looking at research on orthodontists and how they affect sleep. How does that work?
Good question. And it's kind of the code word these days for what's going on in pediatric dentistry and orthodontics, which is airway aware. I do a lot of screening on younger kids. So we do a pediatric sleep questionnaire for the parents to fill out. So what we're looking for is, are younger kids sleeping well? They're snoring and they're up all night. They're just not getting good rest. And then if they aren't, what's the causative reason for that? There's a few things you can do for sleep with kids. Obviously, you want a sleep test to make sure that they actually have sleep disordered breathing or sleep apnea of some sort. Removing tonsils and adenoids for sleep purposes is very significant. There's a very, very significant impact on how they sleep if it's needed. Doing maxillary expansion or widening their upper arch, and when you put those two things in conjunction with each other, there's more of an exponential growth in that airway. So you're seeing a pretty significant change. There's myofunctional therapy or tongue therapy, and where you're putting your tongue. There's tongue tie or maxillary tongue frenems that hold the tongue down from not being able to allow them to bring their tongue up and forward enough and out of their airway. So there's a lot of things. And I would say that it's pretty significant. The patients that I've seen that I'll screen and I'll go through my process and say, it'd probably be a good idea for you to see your ear, nose, and throat doctor. I'm not telling you to get tonsils and adenoids out. That's above my pay grade. But from what I'm seeing here and talking to you and seeing in your child, I think it would be prudent for you to have an evaluation. And if the doctor says that your child is going to benefit from having tonsils and adenoids removed, I would take their advice. And I can tell you, after been doing this for about 5 years as far as airway, I'm 100% on board. There's been significant changes in kids' lives. I mean, significant.
You were touching on expanders. Do expanders only work during that young age when the plate on the top of your mouth is still soft or something?
Yep. So there's two bones that form the roof of the mouth, and around puberty time they fuse.
Right.
It's a process called synchondroses. And they fuse together like all the other bones in your skull. So until that age, you can take and move those bones apart, which is what a palatal expander does. It hasn't changed in millennia. That's the exact same looking device. But you're just taking and moving those two bones apart, which happens very rapidly. You just turn a key and it widens. It's pain-free. It doesn't hurt because they're two separate bones. And then you're just holding them apart for a period of months, 9, 10, 11 months, and allowing new bone to fill in that area. So now you've taken a very, very narrow upper arch and you've widened it. From an orthodontic standpoint, you've made more room. You've created a wider arch, so you're making more room to allow for permanent teeth to come in. From an airway standpoint, you've widened the airway back there a certain degree to kind of help with breathing.
So what if you're an adult? How does that work then?
You'd have to do what's called a surgically assisted expansion, so that gets a little bit more involved. It's still an expander that's put into the roof of the mouth, but then you need to get a periodontist or oral surgeon to give you an assist and kind of, we were talking about doing micro perforations. They would do something similar to that in that midline suture that's already been fused. They could go in there and just free that up, and then you can move it apart. So it's actually A lot easier to do that than it is to do jaw surgery. It's jaw surgery of a sort, but in a much minor form. But again, if you've got adults that are having sleep problems, you have adults that have cross bites, you have adults that have crowding issues, even though it's one more doctor involved and one more procedure involved, it's very successful.
Also, you're talking about jaw surgery. When do you think jaw surgery should really be used during orthodontistry?
Well, jaw surgery is when there's a discrepancy between the top and the bottom jaw. They just don't fit together, in simple terms. That can be from a very, very minor degree to a very, very severe degree. I've yet to see anybody, even the severest skeletal discrepancy, starve to death. So to say that you have to go get jaw surgery or you're never going to eat again probably is unrealistic. But there are people that it looks like a facial deformity. You know, they're like, look, my lower jaw's sticking out, a million miles. I don't want to go around for the rest of my life looking like this. So there's surgeries that can be done to retract the lower jaw, bring the upper jaw forward, and kind of coordinate everything. Obviously, function gets better, but aesthetics is a big part of. And that's a decision that's, again, predominantly made by the patient. It's pretty invasive because you're doing surgery on your jaws. It's done in the hospital. It's multidisciplinary. You've got a general dentist, you've got an orthodontist, you've got an oral surgeon that's involved in the process. So it's got to be a cooperative agreement that this is what we're going to do and this is how we're going to do it. It's definitely for the benefit. Nobody's ever done jaw surgery and said, I'm sad I did that. That was a real pain in the butt. I didn't really want to go through all that. Back at the end of the day, it's like this was a good thing.